The National Institutes of Health, we have Lawrence Buck.
Okay, thank you very much, Mr. Chairman. I'm Larry Tabak, and I'm performing the duties of the NIH Director. That means that I'm the acting director, but I've been in the role for over 220 days, and after 220 days, you can't be acting, you have to be something else. So I'm something else. I really do appreciate the opportunity to speak with you and provide you with a quick update on NIH tribal health research activities and to share some information about NIH appropriations that are relevant to American Indian and Alaska Native communities. First thing I'd like to mention, quite important, and I did mention this at the STAC meeting last month, we have had a change in the leadership of the NIH Tribal Health Research Office at NIH, and Dr. Karina Walters, who is an enrolled member of the Chickasaw Nation of Oklahoma, has been selected as the next director of the office. She will begin on April 24th, which I guess is Monday. She has a wealth of experience and a true commitment to engaging tribal leadership in all forms of health research efforts. And she has certainly demonstrated her commitment to community-based participatory research by being able to sustain collaborations with diverse Native communities, and she has also conducted successful randomized trials with tribal communities. Dr. Walters is succeeding Dr. David Wilson, who is now on assignment to the White House Council on Native American Affairs, and so we look forward to welcoming Dr. Walters on Monday, and hopefully you will all have a chance to engage with her in a not too distant future. Let me give you some information about the NIH budget for this fiscal year. 2023, our appropriated budget is $47.5 billion. More than 80% of that money goes to support extramural research efforts. So it goes outside of the agency, across the country. Just to give you a sense of the scale, in last fiscal year, fiscal 22, we funded about 50,000 competitive grants, supporting more than 300,000 researchers at over 2,500 universities, medical schools, and other research institutions. A couple of weeks ago in March, President Biden, as you know, submitted to Congress his 2024 budget request. And that request, which I defended this morning before Appropriations Committee in the House, it requested $48.6 billion for NIH, which is a 2% increase over this current fiscal year. Within that, you might particularly be interested in some resources to the Superfund. And it's proposed that we would receive $83 million for Superfund activities to find practical solutions to exposure to toxic substances in the environment. And I know this is a topic that is of interest to many of you. According to our data system, which is online and anybody can interrogate it, the so-called RCDC system, Research, Condition, and Disease Categorization System. In fiscal year 2022, we spent $330 million on research that is specifically related to American Indian and Alaska Natives. We're projecting for this fiscal year an increase to $347 million. To put this into context, in 2018, we spent $175 million in this category, so we have certainly more than we were projecting to just about doubling that. Aside from research, our funds also support infrastructure work and community outreach and workforce development, all within the research field. I'll just give you one example of how research money is spent in a project led by Dr. Otakoye Conroy Ben, who was a member of the Ogallala Lakota Nation. She is an environmental engineer at Arizona State University. She and her colleagues are conducting wastewater testing with tribal communities across the country. And what they're doing is they are showing that with regular wastewater testing, you can track the levels of virus that cause COVID-19. Dr. Conroy Ben hopes that this groundwork that she is laying will offer a template for any tribe with a wastewater treatment system so that they can monitor COVID-19 or any other thing that finds its way into wastewater. It can be a very powerful approach. It's also used, for example, to monitor the appearance of opioids in the system. We have a number of programs that place the focus on responding to health disparities that burden Native American communities. We have several new funding opportunities that will be announced soon. A Native collective research effort to enhance wellness, the so-called NARCH program, which I hope some of you are familiar with, Native American Research Centers for Health. That one is particularly important because the resources go directly to the tribal nations. And so I hope that you pay attention to that one if you are interested. The IRENA program, which stands for Intervention Research to Improve Native American Health, it's supported over 50 projects over the last decade or so. And until May 17th, this IRENA program has two open program announcements, one for our sort of standard NIH grant, what we call an R01, and the other for a smaller version of the standard NIH grant. We call it an R21. And this is, these are a rewritten version of the program will be ready for May 2024 submissions. So we hope that we are able to solicit things from you. Just to touch upon this, because I know it was important to Native communities, the NIH Community Engagement Alliance, which we call SEAL, works closely with communities that were hit hardest by COVID-19, and we have initiated a program to work specifically with American Indian, Alaskan Native, Native Hawaiian, and Pacific Islander communities. And we are currently receiving application to foster community-engaged research. This program allows you to consider both short-term as well as longer-term collaborations with community partners and healthcare systems. I know in the past day, yesterday, and perhaps again this morning, there were discussions about the opioid and fentanyl crisis. National Institute on Drug Abuse, which is one of the 27 institutes and centers at NIH, is funding a number of clinical trials that are trying to establish effective treatments for opioid use disorder, specifically among American Indian and Alaskan Native people. NIH-funded researchers are partnering with American Indian and Alaskan Native communities, tribal nations, and other organizations to build a science around a program supported by other parts of HHS, in particular SAMHSA and the CDC. NIDA is very committed to effectively engaging with communities to ensure that the research is designed to best serve their needs or your needs. In August, Dr. Nora Volkoff, who's the director of NIDA, will present on the intersection of opioids and the COVID-19 pandemic and participate in listening sessions with tribal leaders at the Tribal Opiate Summit at the Tulalip Tribes Indian Reservation. Now, we understand that there is an urgent need for additional effective treatments for substance use disorders as well as psychiatric disorders, including depression and anxiety and post-traumatic stress disorder. And so in last fiscal year, we invested more than $25 million in studies that focused on psychedelics. This includes research which characterizes their effects so that we can better understand the mechanism of their actions and to assess both their safety and efficacy and obviously their therapeutic potential. The term psychedelics is often used to capture sort of classical Western substances and other, drugs, with hallucinogenic properties. I am aware that among your native customs there are substances that probably fit in this category, but we don't know about them, but they could potentially be very important to the native treatments that you use. NIH is funding research that is developing analogs for this medication class, hopefully with an improved therapeutic profile and a standardized therapeutic profile. If you go from plant to plant, there may be variation in the potency and so forth. We also discuss risk mitigation strategies that consider trial settings from other practice settings. If you'd like more information on NIH grants by category, including information about any grant that we fund, you can interrogate the NIH RCDC system at the webpage for NIH report. If you go to report.nih.gov, you can click on categorical spending for every single one of the categories, and it gives you probably more information than you even want, but we do try to be very transparent about all the things that we support. While I'm here, if I may, I just would like to talk a little bit about the All of Us program. This is something that I've discussed with the STAC on several occasions, and I just did want to give you a quick update. For those of you not familiar with the All of Us program, it's a program that is building a cohort of at least 1 million people across the nation. It will be the most diverse health database in history. It already is. We have extraordinary participation from many, many different groups across the country. We plan to hold formal tribal consultations this fall to evaluate the All of Us tribal engagement efforts and also to consider the potential impact of data access, use, and protection. And this will also include, of course, within the consultation, an update on the program's approach to tribal engagement and discussions about how to integrate information from self-identified American Indian and Alaska Native participants in the All of Us Research Hub. But before the consultation occurs, we will have a series of 4 virtual listening sessions to provide members of tribes, other individuals who are interested, to hear more about the All of Us program and to answer any questions sort of as the prelude to the formal consultation, just to get everybody to the same baseline information. We'll provide the dates shortly. Federal Register notice will also be published announcing the consultation. And again, for any information about the program's tribal engagement, just type in your favorite browser All of Us, and it's the #1 hit. That's where you'll go. So just to close, because I know we want to have time for discussion and questions. The Tribal Health Research Office at NIH and in the All of Us research program and indeed throughout all of NIH, we hope that we are continuing to improve our communication with tribal nations and our collaborations. Because of the health disparities that you know all too well about, we are strongly committed to helping American Indian and Alaska Natives find appropriate answers to address these problems and to, of course, improve health through research. So I want to thank you for the opportunity to share the updates, and of course I welcome any questions. My colleague, Ms. Cauzo, put a two-pager highlighting some of the specific activities that NIDA is doing related to opioids and fentanyl use among tribal American Indian and Alaska Native communities. So it's just, it may be back to front, I don't know, but it's a two-pager, and it may have some information in it that you're interested in as well. So with that, Mr. Chair, I will stop and be pleased to answer any questions that you may have.
Brown, do you have some? Nick?
Yeah.
Go ahead.
I just had a few questions. I know NIH has a large role in some of the work that we do rely on. I think there's room for improvement in our communities, though. We do studies, or we participated and worked with NIH when we were part of the vaccine trials, and I really appreciate the NIH's leadership in helping us work on and develop a tribal ownership of our data agreement between us and Novavax, who we were, I didn't mind being a guinea pig, but I was appreciative that the data that will be collected will only be used in respectful manners. And some of the things that we had to go through was an IRB process at home. And we'd like to see, with a lot of the funding that NIH has, is support funding or find a way to get funding for supporting IRBs in communities so that we can do these type of things more. It wasn't an easy conversation in our community. There's a lot of trauma because of how the government done things to our people before, and we had to navigate that. But what helped was leadership working with our health experts, working with NIH, and reassuring that we're doing this the right way and that we're going to protect the data and we're in the driver's seat, and taking that to heart, the trauma that has happened. So I don't know what thoughts there are with getting funding directed for those type of things. One of the other things that I'd like to see is in a lot of our efforts, we talk about cultural healing. We talk about cultural practices. They're known to be tribal-based practices, and we know how to do them. But there's a difference between tribal-based practices and evidence-based practices. And it is a long process to get things through the evidence-based practices so that we can make those practices sustainable. One of the things that we're doing, and we're actually going to Iceland in 2 weeks because we have some tribal-based practices. But we found a model, the Icelandic harm reduction model, that mirrors our own cultural way of thinking. And that is evidence-based. NIH did a study on that. And so what we're doing is we're using that Icelandic harm reduction model and piggybacking up. So we're collapsing time frames. So we don't have to go through this long process. So I'd like to see NIH work more with tribes in helping tribes turn tribal best practices into evidence-based practices so that they're sustainable. I also will say that we don't want to share all of our cultural stuff and to each tribe their own, but we can find a pathway generally to do some of these things and support tribal practices, and we need your help to do that. And so if there's any thoughts that we can get with NIH, or if it's offline conversation, but really be strategic on that, I'd like to appreciate that. Thank you.
So thank you. Those are two very good and very important tangible things that we could be doing. I'm very pleased that you view the work on the Novavax vaccine to be, a good way to do things, and if we can replicate that for other things, then perhaps we'll be on more solid ground. And your point about, traveling to Iceland, yeah, I mean, we should be able to do more here. So those are two very, very good suggestions. Thank you. And we will make sure that once our new throw leader is on board and has equilibrated a little bit, that there's a reach out to further the conversation with you about that. Thank you.
Chief Smith. Phil.
Thank you, Andy. For the record, my name is William Smith. I'm the chairman and Alaska area representative of the National Health Board. As a Vietnam War veteran and retired Army sergeant, I'm proud to have served my country and continue to serve the public by serving tribal nations through the National Health Board. Tribal nations continue to stress the importance of their concern in relationship to data sovereignty, data privacy, and most important, allowing other researchers to potentially access data already collected. During the last ACT meeting and the committee request that NIH establish an official procedure for tribal nations to report any academic partners, institutes, or research who violate tribal sovereignty, tribal law, or any agreements that may have come with the tribal nations. Well, tribes can contact NIH and the Tribal Health Research Office. There is no formal policy for tribes to seek relief from such violations. We are urging NIH to make steps to consult with tribes to develop and formalize a procedure to address these issues. Tribal leaders have regularly expressed concerns about the access of NIH tribal consultation. Tribal leaders often do not know about the consultations until after they have occurred and can have difficulty gaining access to the consultations. Partner organizations are often not in the loop about these consultations to share the information. The President budget is a powerful tool for planning and notice on executive actions, even if Congress is inclined to adopt other policy priorities. National Health Board recommends that the HHS includes comments and plans to achieve these tribal requests in the 2025 budget.
So thank you for those points. It's a poor excuse as to why we haven't started working on a formal policy yet, but we are waiting for the arrival of the new office director. But that will be something that we will ask her to take on. With regard to getting the word out about consultations, this remains a bit of a vexing problem for me personally. I've participated in quite a few consultations over the last few years, and I'm never quite sure if we've done enough to ensure that the people who need to know do know about the opportunity. I mean, I appreciate everybody's busy and not everybody can come to everything, but so again, if there are better practices that we should be using to get the word out, because we have done many consultations over the last several years. There is attendance, but I have no way of knowing, nor do my colleagues have any real way of knowing, is it really the right people who are there or not? And so any help that you or others could offer in ensuring that we get the information to the right place so that everybody who does need to know knows, we would be very grateful.
Yeah, thank you. And yeah, there's a difference between the consultation and the listening session. And when you come in the room and the tribal leaders and the officials are not there, it shouldn't be classified as a consultation. It should be classified as a listening session. So when you're right about who needs to be in the room, the notification needs to be sent out to the tribal leaders. No decision about us without us, because if we're not at the table and the right tribal leaders are not at the table, it can't be a true consultation. So thank you.
Yeah, I didn't see any hands, so I'm going to take an opportunity to say something about 4 years ago, I lost my sister to cancer, and around the same time, my dad was really ill and in the hospital. And my dad was totally against marijuana, but my sister needed it to be able to have, I guess, to be able to eat the foods to gain enough weight to overcome the chemo and radiation that she was going through, the treatments, and it really helped her with the pain. If she didn't have it for the pain, she would have been really hurting. And anyway, I was telling my dad as he's pushing those, the button to give himself the morphine, Dad, that marijuana is actually doing the same thing that your button's doing, but I can talk to my sister and she can comprehend with me. You'll be sleeping in a few minutes, and I won't be able to visit with you when time is really critical and you want to spend as much time as you can with your loved ones. And anyway, I really believe the research needs to be looked into. I was in a Head Start meeting, a parenting meeting, and it was when methamphetamines first came out, and the clinical provider that was given a parenting class to the Head Start parents was a student of Washington State University, where they dissect the brain and all that, and he was telling us the difference between natural drugs and drugs that are synthetic. Says there's no reversing what's the damage is caused from the synthetics, but the natural drugs, he said that you can actually potentially get back to normal. And with the opioid crisis and the fentanyl deals that we're dealing with, and they're given a different kind of opioid to our patients, I don't know if there's any research to see if they were to administer medical marijuana in that opioid place to wean them off of that kind of what we call addiction. I think they could probably come back to normal. I don't know what kind of damage is happening to the brain or whatever, but anyway, when I first got elected in 2003, I got sworn in, and we had our celebration luncheon, and our council reorganized when you get sworn in. I got the Health and Human Services Committee by a flip of a coin in our reorganization. Anyway, they says, well, Andy, you're HHS chair. You got to be down in Lincoln City, Oregon tomorrow at 8 o'clock in the morning. So the secretaries, you got to go meet with them. They'll get your flight arrangements, your rental car. And so I had to tell my wife, I got to go. I barely couldn't even finish eating my lunch. And she says, really? That was my orientation to council. But I got down there, and the meeting was an arch meeting. And ARCH is, research. And then I started, I became a part of HRAC and with IHS, and I learned about the hippy dippies, and the Portland area actually hosted a research conference, and I couldn't believe how many, I call them mad scientists, but anyway, there was a lot of our people learning from the research from ARCH grants, and I want to thank NIH for, and there is an ARCH grant that the Healing Lodge of Seven Nations is working on with Harvard, and it is studying traditional practices, and Nick talked about tribal practices, and when I was part of the SAMHSA work or TAC, I also they always have their national meetings the same time as our TAC, and anyway, Darryl Strawberry belongs to a group from Florida, and he uses Christianity, and it's faith-based practices. So I usually jump on and try to get on right after he talks about, making a connection to what is I call it evidence and faith-based, but with our culture, we live our religion based on the seasons and how we interact with our spiritual well-being. Anyway, I just wanted to say that it is something that needs to be definitely be billable to provide those kinds of services, because it works. The Healing Lodge is proof of it. But I want to, you don't have to answer me for anything. I'll go with Nate, and we'll see if anyone else.
Okay, appreciate that, Councilman Joseph. I had, I guess, one comment, one suggestion, and one question. The comments on NARCH, you talked about NARCH. I want to let you know that the Portland area does support that, and we are asking for it to be permanent and to either meet or exceed the current funding level. My questions on, I know you talked about some of the studies you guys are doing, and I guess my questions on medicinal marijuana. If you guys are working with, like, say, the VA, in that study, or just I'm a Gulf War vet. After coming back from the Gulf War, and I think NIH was a part of studies for Gulf War illnesses, just in my research, and I quit taking all my meds from the VA, and I turned to medicinal gummies, and it's working, but the problem is, a number of states have legalized marijuana. We all know that. And the federal government's really not backing off on their stance as far as what marijuana is. But I think it's important that somebody does the studies, that we get that scientific background evidence that marijuana is safe. I've been on it for well over a year and a half. And I'm doing better than when I was on medication through the VA. So, but I just want to know what you guys are doing, if you're doing anything, if you're gonna do anything, and if you're not doing anything, how can we get you to do something?
So, in fact, we are studying the beneficial effects of marijuana. Part of the challenge are some of the federal regulations that our researchers have to adhere to as well. We actually have a source for marijuana, but it's of very poor quality. And what is now available as it becomes legalized in states around the country is much, much more potent. And so we're trying to work to allow our researchers to have access to the more potent materials. Along with that, we're also trying to study the value of extracting the active ingredients of the marijuana so that you do not have to use it as a combustible product, but rather can use it, say in tablet form. And that would potentially give you a much more uniform dosage, because with a combustible form, you go to one vendor, you go to another vendor, it may be different. The last thing that we're doing, and this is sort of the flip side of the question, is we're also studying marijuana in youth. And unlike an adult such as yourself, with younger people where their brains are still developing, the use of marijuana is really contraindicated, because within your brain, all the synapses are forming. It's just part of the normal development. And the marijuana appears to compromise that in some ways. So we've got to look at both sides of it. But yes, we're definitely doing this. Some of the work is done in collaboration with the VA. We also collaborate with other agencies. And, as we've talked about these different things, these are some of the things where you have in your community's lived experience that could position you to actually study these things within your native communities, and that's the long-term goal. Is as important as the university-based research is, even more important, frankly, is research that's based in your communities with your own community members, doing the research. That's why the NARCH program is so important, because it's allowing us to train people, to do investigations. And so, we'll get there. We just have to continue to work together and, point out our missteps and, give us counsel to help us navigate. But, we're going to get there.
Any other questions? I don't see any. I want to thank you for your presentation. We appreciate all the work that you're doing.
Thank you very much. I have a pleasure seeing all of you again.
We have Patrice here, and I can't read your Michelle is here. Michelle Patterson. So go. You're on. We'll wait for you.
Well, good afternoon, esteemed tribal leaders and Councilman Joseph. My name is Michelle Patterson. I am the director of the Budget Division within the Office of Legislative Affairs and Budget for ACF. I am going to try my hardest to fill in for January. I know I am a poor substitute. Our Assistant Secretary, January Contreras, could not make it at the last minute. I know she is gravely disappointed in that. Ever since she has arrived at ACF about a year ago, it is very clear what her interests and priorities are for Native Americans. So for those of you who aren't intimately familiar with ACF, the mission is to foster health and well-being by providing federal leadership, partnership, and resources for the compassionate and effective delivery of human services. It's a mission that is very important to each and every one of us at ACF. And we achieve that mission with you as tribal leaders and your staff who provide the direct services to children and families on the ground through programs like Head Start, tribal home visiting, child welfare, low-income home energy assistance, and other programs that we have in ACF. But before I provide any updates that will help inform our discussion on the FY 2025 budget, I want to pause and introduce our new commissioner in ACF, Ms. Patrice Kunesh. Appointed by the President and confirmed by the Senate, she is a strong advocate for early childhood, native language programs, and self-determination. We will be relying on her advice and depth of knowledge as she serves as an advocate for Native American affairs within ACF and HHS. So I know that she is eager to get out and meet everybody over the course of her tenure. We're all looking forward to this too. And I just wanted to turn it over to her to say a few words.
Thanks, Michelle. And Petuwaste, Mitakuapi. Thank you. I'm so happy to be here with you. And a few of you were here yesterday as I was formally sworn in on the stage. I was confirmed by the Senate on March 8th, and immediately they got me technically sworn in, so I was able to dive in and do the work at ANA. But yesterday was a beautiful ceremony, and I really appreciated those of you who could attend. I am on the job 6 weeks now, and it's just been an exhilarating experience to learn all things ANA and to really appreciate the incredible work, the broad scope of responsibilities and support that ACF is providing our Native, tribal, Indigenous peoples. I really am completely committed to our nation-to-nation dialogue with tribal leaders. I have worked for tribes my entire life. My background is Standing Rock, Lakota, and at a time when my grandfather was growing up on the reservation, and the relationship between tribes and the federal government were pretty poor, in fact, pretty non-existent. And it was really more of a fight for the onslaught of programs that would actually be the demise of tribes rather than building them up. So I am a true supporter of tribal self-determination, of supporting our Indigenous peoples in the best way possible, according to their needs and according to the way they're designing the programs and services in their communities. I'm really, truly honored to be part of this administration, and what I've seen over the course of the last year and a half, I've found that the deep respect, the really genuine engagement is demonstrated every day in so many different ways. And I would like to demonstrate that to you as well, my sincerity in terms of what I'd like to do and work with you on, especially through ANA, but larger policy issues that affect all of our communities. I really am here to help Native families and children flourish and tribal economies to really thrive. I do believe that the investments that ACF and ANA makes into our Native communities is the heart of our work, because it's your communities that you're taking to the next level. I also know that our grant process across the federal government can be really challenging. So one of the priorities that I've just had good conversations with is to make our grants much more accessible to tribal people and Native serving organizations so that we can disperse the funds readily and broadly. In addition, I've been truly impressed with the return on investments that early childhood development has with our Native children. And these are long-term returns on those investments, the resilience, the education outcomes, the support in economic development through jobs and so forth. And when I see that coupled with Native languages, it's just exponential. So that's something that ANA can really do, support our grant work and the enormous support we're seeing from this administration on Native language preservation, maintenance, and so forth. And I'd love to hear from tribal leaders such as yourselves about where we need to be and how we can really do that work. And finally, I'm a champion of policies that enhance the well-being of Native people and advance tribal self-governance. So whatever I can do on behalf of you and your work here, please let me know how I can be effective, how I can be a partner in that. So Wopila Tanka, thank you very much, as I say in Lakota, and I'll turn it back to Michelle.
Thank you. My purpose here today is to give you guys an update on what happened in the 2024 President's budget in order to help inform a discussion about 2025. So, for those of you who didn't read this document when it was released last month from cover to cover, I wanted to give you a few highlights of what was in the budget for ACF. The whole point is to encompass the scope of the services that we provide. It is both a budget request, but it is also a legislative request for changes that we would like to see to enable our programs to operate better. So this is information that is just to specify what might be important for your discussions. One of the most important things is that it reflects our nation-to-nation commitment to tribes with a request of $87 million for Native American programs. This is $27 million above the 2023 appropriation, which was $50 million. We have divided that request into 3 sections. So of that $27 million above, $5 million of that is just for the expansion of the existing Native American language preservation programs. So we know that that is a very important mission. This would increase that budget and could support up to 20 new grants. In addition, there's a request for $7 million for a new program. This program is called the Tribal Integrated Early Education Services Program, and it's the idea to develop a comprehensive, tribally driven early education system. It's a demonstration project that would respond to recommendations that we have received from tribal leaders to integrate the education, child development, and physical and mental health services into a single program. And lastly, within that request, there is a request for $15 million for the strengthening trauma resilience of Native demonstration projects. So the idea is to embed trauma-informed practices across all services that engage Native American children. The projects would establish collaborations that include schools, behavioral health services, physical health care, social services, youth development organizations. It's all the panoply of groups who work with children within the communities. That is specific to the request for the Native American programs, but of course ACF has more than that. The big thing, as Patrice mentioned, early education. This budget has a proposal for $600 billion over 10 years to really expand child care for all children and to provide for universal preschool. So that is something that the administration strongly supports and has from the very beginning. With this investment, states, tribes, and territories will be entrusted to increase child care options and preschool options for about 20 million children. This would also create pay parity and cost of living adjustments for the providers of these programs. And this is in addition to the $13 billion that we've requested for Head Start and the $9 billion for the Child Care and Development Block Grant. The President's budget also proposes to reauthorize and increase funding for the Promoting Safe and Stable Families program. This program provides flexible funding for community-based family support, family preservation, family reunification, and adoption promotion and support services. This is the part of the law that authorizes funding for the state and tribal court improvement programs. With that, not just the reauthorization that we're requesting, we're looking for an increase in funding for this program. Specifically, we're looking to go for the set-aside for the tribes from $10.4 million a year to $18 million a year. And this would also double the funding set-aside for the tribal court improvement program. So those are some highlights from the budget side, and just really quickly wanted to talk about some of the legislative proposals whose intent is to provide the additional flexibility that Patrice has alluded to that we know that people are searching for. So we have some legislative requests that we are making to Congress, things to change the underlying law. Within Head Start, one of the proposals is to revise the eligibility requirements for American Indian and Alaska Native Head Start programs, along with the migrant and seasonal Head Start program. And this would allow us to include more children within the Head Start programs, because in the 2020-2021 school year, the American Indian and Alaska Native Head Start program served over 21,000 students in 150 American Indian and Alaska Native Head Start programs and 58 early Head Start programs in 26 states. So many more tribal students would be eligible for these critical services and benefit from the educational opportunities if we can get Congress to expand the eligibility requirements for this. In addition, we've got some child welfare proposals. A key one is in the Title IV-E Prevention Services Program, and this is something that has been asked for by the tribes over several years. If it is enacted, it would allow tribes participating in the Title IV-E agreement to use interventions adapted to the culture and context of tribal communities, exempting them from the requirement to use only programs rated as supported, well-supported, or promising. Currently, this flexibility only exists to tribes who are running the program directly, not those tribes who have state agreements. So this is a flexibility that we know that has been asked for, and we will continue to press Congress until they act on that. It would increase the federal share of program cost for the Title IV-E prevention services programs so that ultimately for many tribes it would equal about 93% for the feds paying the cost of this program. So we think we're making a great start with this budget proposal. We know that ultimately Congress has the final answer in this, but we think it's important for you to understand how this reflects our priorities and our commitments and our interests. And to the extent that this helps us begin a discussion about 2025, we're happy to let you know about it. And I am looking forward to hearing from all of you.
Okay, go ahead, Gil.
Good afternoon. My name is Gil Vigil. I'm a council member from the Pueblo of Tesuque, New Mexico, and I'm also the president of National Indian Child Welfare. First of all, thank you for your report. It's gratifying. Before I move on, congratulations to your appointment, Patrice Kanush. How mitakiapi on penkawaste. Welcome to ANA. It's always gratifying to see our tribal members be put in these kind of positions. But just to reflect on the comments about Head Start and the Title IV-E legislation proposed, I think that's a great move because yesterday we had a meeting with Head Start because of low enrollment. And the challenge has been over income. I mean, income-based criteria. We have kids, and this is how I start my comments. Head Start works, but it's not for all kids because of the income requirements. So the reason the over-income requirements applies because those people that have gone through Head Start are now professional people because they got their education, but their kids aren't eligible. And as tribal leaders, it's our responsibility to educate our kids, whatever income that they're at. And Head Start kind of prohibits us from doing it. So I'm glad to hear that legislation is being proposed. I think we were informed of that early on this year at a Head Start conference in Albuquerque at the Isleta Casino, that might be coming down. So, and certainly we support it, and we will do our due diligence in making sure we advocate our congressional delegates from New Mexico and all Indian country to make sure that that happens, because I think that would be a great move. So with that, I have some written comments I want to make on behalf of NICWA. First of all, the tribal child welfare programs are increasingly becoming more effective at addressing the core issues that cause Native children and families to enter child welfare system and producing outcomes that outperform state child welfare system in many cases. Investing more in tribal child welfare system is not only appropriate based upon the federal trust relationship to tribal nations, but is also a matter of supporting the most effective approaches to child abuse and neglect that impact Native children and families. The need of these services is the result of generations of Native families struggling with historical trauma that has visited upon their communities through boarding school and more recently state and private child welfare system that continue to remove Native kids, the Native children, often unnecessarily, in large numbers from their homes. Even today, we see 14 states with disappropriation replacement. English is my second language. The appropriate placement of Native children in their first foster care system, and many of these states may have low rates of reunification of these children with their birth parents or relatives. A key element of the solution to these negative trends is to further invest in tribal welfare programs so that tribal nations can increase their capacity to serve more of their families and also be more available to their state partners when children are in state child welfare system. There are no shortcuts or silver bullets to solving these problems. Tribal nations are the best situated and the most knowledgeable when it comes to understanding how to address these complex issues, and their expertise help improve state responses too. Regarding funding, not unlike states, tribe needs reliable and flexible resources. In some cases, this may take policy or legislative change that you've been talking about. But in other cases, it's more about the level of funding tribal nations have access to. Programs like promoting safe and stable families are a good fit for tribal efforts to decolonize their programs, but the funding levels, especially in the discretionary side, provide grants that are too small to build these types of robust programs that could help children avoid foster care. Targeted investment is in existing programs that work well for tribes, combined with supportive policy change, are the more sure approach. Our written testimony provides NICWA's recommendation for ACF tribal child welfare programs and the HRSA home visiting program, all of which are important to support child welfare system in tribal nations. We also want to thank the Biden administration for the FY 2024 budget recommendations, many of which are very helpful, and a special note of appreciation for the administration's policy recommendation to extend flexibility tribes to the Title IV-E agreement with states that can help them provide more culturally appropriate prevention service. This morning, I know, Chairman, that SAMHSA made their presentation. I was not able to make my comments to that. So for the record, can I make those comments to that about SAMHSA?
Yeah, I guess if we could be brief about it, because we got actually looks like we have 20 minutes. So.
Okay, no problem. We can put this in writing and we'll submit it to them also. Thank you. And again, welcome, Commissioner. And I guess the most important part of my comments is one of the representative made a statement about hope we're not talking about these same things a year from now, 2 years from now, 5 years from now. Because I have been at this desk and this table, and we talked about Head Start issues. And finally, Head Start was listening to us because the federal standards and guidelines were this thick. Now they come down to be a little bit thinner, but they're still there. And sometimes those standards are the hindrance. We need more flexibility to allow us to perform. But the income requirement is the biggest issue right now. So we can get legislation to take care of that, to allow tribal sovereign nations to allow to run their programs the way they need to run them would be more successful. Thank you.
Jennifer?
Greg, Jenny Webster Neungets. Good afternoon. I'm Councilwoman Jennifer Webster from Oneida Nation and also a member of ACF TAC representing the Bemidji area. I want to talk a little bit about the tribal match requirement, the child support match. Oneida Nation strongly supports updating the federal regulations to permanently eliminate or reduce the non-federal share match requirements for all ACF programs, including 4D child support. Oneida Nation has operated its own 4D child support agency since 2008, which assists Oneida families by obtaining financial support that enriches the lives of our children. We are one of 60 tribal child support agencies across the country. Tribal child support programs like ours are required to provide a 20% match in order to receive federal funding, also known as non-federal share. This match requirement creates financial and administrative hardships for tribes. During these difficult economic times, tribes have limited resources and often have to make difficult financial decisions on which social programs will receive funding. If the non-federal share match requirement was eliminated, it would provide all tribal 4D programs with the opportunity to take a proactive approach to offering services that ensure the overall well-being of children and families we serve. It would also reduce barriers for tribes to establish their own tribal child support programs, increasing tribal sovereignty. Our request, we ask the ACF to reduce or eliminate tribal match requirements across all ACF tribal funding, including 4D child support. And then also I'd like to speak about Head Start, the funding for the workforce, and expand or eliminate the income eligibility that you spoke about earlier. During the recent ACF budget briefing held on March 16th, ACF shared that the President's budget included two important Head Start proposals that the tribes have been asking for. One, increase Head Start wages and provide cost of living increases, COLA, to bring Head Start on par with elementary school teachers who often have the same qualifications. And two, a legislative proposal to provide more eligibility for tribal, migrant, and seasonal Head Start. The proposal would allow tribes to determine which children would benefit most from Head Start in their communities and prioritize accordingly. The nation strongly supports increasing funding for Head Start workforce. Like many tribal programs, we struggle to recruit and retain early education staff for a Head Start program. Greater funding for a Head Start workforce to make these careers competitive with K-12 is critical. We also support eliminating income eligibility for tribal Head Start. Income eligibility is a hindrance for many tribal Head Start programs, with many states implementing 4K options in their educational systems that have no income limits. Head Start is losing child participation due to tribal over-income parents opting into the 4K programs instead. Limiting access to Head Start due to income takes away the emphasis of cultural language programming for our children in their early years of development. In our request, we recommend that income limits be eliminated from Head Start eligibility criteria. Eligibility should be focused on tribal enrolled and descendants so that these children have equal opportunities and exposure to culturally relevant curriculum, practices, and language. Our other request, all American Indian Alaska Native children should be categorically income in recognition of their increased vulnerability due to the high rates of adverse childhood risk factors, health disparities, historical trauma, and damage to cultural identity. And then also I want to speak about the Title IV, child welfare funding, eliminate the burdensome reporting requirements. Our child welfare agency shared how burdensome the reporting requirements are for the grants that they receive, especially 4B, the child welfare grant that is through ACF. Title IV reporting alone requires assistance from our enrollments office, our statistician, accounting, and our child welfare agency to complete. The narrative alone last year was over 60 pages, plus the additional supporting documents. While we appreciate the funding, this is just one of the many grants that we must pursue and covers just a small fraction of our agency's overall budget. So our request, we asked ACF to reduce reporting requirements, simplify the grant application, maximize the flexibility for all funding, especially for 4B child welfare. In our request, we again express our support for expansion of self-governance to all of HHS, including ACF, to provide maximum flexibility to tribes. And then I wanted to touch on recruitment and the burnout. Indian Child Welfare, along with other child welfare agencies across the nation, are seeing a dramatic decline in applicants interested in working in this field. The work has taken a toll on our already strained short-staffed team with higher than normal workloads. There needs to be a conversation at the federal level on ways to promote this field of work or ways to make the work more manageable and less stressful. So my question is, how can tribes and ACF work together to recruit and retain the workforce for the child welfare agencies? And then also to the ANA, to the new ANA Commission, we want to congratulate you. Oneida Nation is a recipient of 2 ANA grants. We'd like to invite the Commissioner to Oneida to see our programs, which include Jitnio Gualihola Language Nest and the Strengthening Oneida Families using traditional Oneida language systems. Yamanko, and thank you.
And Nate?
Appreciate that, Councilman Joseph. I guess a couple things. I fully support every single thing that Jennifer said. We live that every single day. As far as low wages, supplementing the program by the high 6 digits, both Head Start and child care, the requirements that was talked about, that's barriers. Our wait list is, for both Head Start and child care, is humongous. We're in the process of building a new Head Start right now. So we do thank the Office of Head Start for helping with some of the funding. Head Start's important. You know, anytime the government talks debt ceiling, some of the first programs they threaten to cut are any of the children programs. You know, so we have always supported Head Start, always. They've been in positions like that numerous times in the past 2 decades. You know, so we've always fully supported the Head Start program because our kids benefit. Can't even explain how much they benefit because not just the kids, but the teachers, the requirements, having to get their education, and that was talked about. We end up losing them guys because they do go to the state school for a lot higher pay. So what we end up doing is having to match the state school. So that's probably something, I think that's something the Office of Head Start should be doing. Keeping with inflation. I don't know if our budget has changed much in the last 2 decades. My guess is probably not. Although we've tripled in size, we're offering more services. We've been offering our Makah language class through the Head Start program for the last 35 years or so. So a lot of these programs are super beneficial to our kids. One of the biggest things that definitely needs to be addressed, and it's been an issue prior to COVID, but during COVID it's amplified, and that's the mental health of our kids. So my request is to work with both IHS, you folks, and SAMHSA, and us as tribal leaders in figuring out how we can address this mental health issue. I mean, everything's a circle. You know, our epidemic, our drugs, our mental health, it comes full circle. It affects all the programs that we just talked about. ICWA, MINOC, I mean, you name it. If we can catch it when they're 4 or 5 years old, we're going to save a lot more money rather than when they're in the system. And they graduate out of the system as 18-year-olds, and they have nothing to do. They have no skills. They have, I mean, the list goes on and on. I mean, we've seen Washington State, the position they've been in. with the youth that are graduated and out of foster care, and it's not good. You know, we can't. It was said, I think Gil just said it. You know, we don't want to be here next year talking about these same issues. You know, if we're in a position where we can address them, then, you know, let's address them. But every single thing that Jennifer said, you know, we fully support. So I appreciate it.
Yeah, I wanted to kind of hit on the same thing that Nate just brought up. But I remember being a young parent, and it was before TANF even was about, but there was Head Start. My tribe gave this one-time COLA back then, and it put me over income by $8 in a year to receive LIHEAP funding to help, you know, heat my home and in the winter time, and I overqualified for commodities at the same time. But I was over income for one of my children for Head Start. Then HUD sends me the bill and takes my whole COLA away from me, put me back into that poverty line, but according to the guidelines, the poverty for different programs weren't adjusted. And then I spoke a little earlier today. You know, a couple of years ago, I could go shopping for my family, and it's about a 90-mile round trip to go shopping. So that's an added cost, but it cost around $200, you know, to get enough groceries to make it through to the next payday. Now it's costing about $600. And just that short turnaround, you know, the cost of fuel went up, the cost of all these different groceries went up. You probably see it here just as much as we do at home. Anyway, but we don't have a grocery store down the street. What I was kind of getting at with what Nate says, I talked earlier about attending a Head Start parenting class, and they were talking about methamphetamines, about it being synthetic, and you know, I got to sign the certificates afterwards because I was tribal leader and attended, and I really wish that SAMHSA, CDC, and IHS could, and HUD, if we could all meet together and pull some resources together for some parenting classes on prevention and setting up asking the parents, what do you want your child to be when it gets when they get older? It's kind of set up a plan for them so that they could kind of follow, because of the boarding school way of life, a lot of our young people weren't really brought up kind of in the home to deal with parenting, anyway, I just really think that there's got to be more prevention between the different divisions of HHS, but HUD needs to be a part of it, because I really wish that our parents that get these increases, that they can actually keep them and better their children's lives. The HUD policy will take it every time, and that's really a crisis that, you know, causes depression to families. I had to become a better hunter, and I had to go out and spend a lot of resources to bring in firewood for my own home, and it was a good workout. But I survived it. But my children had to suffer from the impacts of not having I would say the things that average children get to have. It's just life how it is on a reservation. And I always say I'm probably one of the average ones. I was a working dad, but some parents are single family mothers raising their children, or there might be grandmothers raising their grandchildren, and so those income issues are really, I would say, a lot harder on tribal people than elsewhere. I could imagine how it is in Macaw to travel so far for their goods.
I think one other thing too, Andy just mentioned, over income. I know people at Macaw that are placements, permanent placements, and they're over income, so they're getting penalized for taking in a foster kid. Is that right, or for being able to have access to both child care and Head Start, being at the top of the list? It's a foster kid. Went through the system, got placed with somebody that's over income, and now the kid doesn't get services he should be getting?
That is a good question. I cannot claim to be an expert on the interplay of all of the program rules, but it is definitely something that ACF needs to consider.
Zandavi. My name is Claudia Washke, and I'm with the Shoshone-Bannock Tribes. Prior to taking my role as a council member, I worked at early childhood. I was the early intervention manager for the Shoshone-Bannock Tribes. So I've seen what Head Start can do, and I've also seen the barriers that Head Start as well as child care provides on the reservation to our Native families. And I say that because the poverty guidelines do create a problem for the majority of our parents on the reservation, for those that work. But also the poverty wages that our staff there at the Early Childhood Center in Fort Hall had to encompass while the duration of their employment there. We had many over the past year leave employment at our facility simply because the funding for their wages isn't enough or sufficient enough for them to raise their families. It's sad when your staff have poverty wages enough to where their children are sitting in the classroom and their children are in the classrooms because they qualify. So that's an issue for me, is when our staff, and these are longtime members of our staff, they have been working there for 10, 15 years, and they're barely making $10 to $12 an hour. It's very sad for them to live in those kind of conditions. Me as a tribal member, as well as a council member now, I see where I can help them. And it's here addressing this issue with all of you, because I don't think that our staff should have to have poverty wages so that their children can benefit. I know that there's a wait list, the majority of our children, to get into Head Start, as well as to get into child care. I myself, I knew what the wait list was for our local facility because I worked there. When my grandson was born, I made sure that his application was turned in within days of his birth because I knew there was a wait list. He was finally able to get into the program in December of this past year. By that time, he was 18 months. Prior to that, when his mother became incarcerated and I had to take custody of him, I was paying $800 a month in child care expenses. And that was off the reservation, simply because we were waiting for his spot to open up. Now that he's in our child care facility, I'm thankful for having to wait that long, because I only pay $85 a month now. And I know what the expense is off the reservation. And there's so many people, so many parents, grandparents who are on that wait list, who have to make means and have to compromise their monthly budgets just to provide child care, to pay for child care. And so I would like to see more options for child care to be provided off the reservation for parents, but for a program to be paid under the tribe, where the tribe can manage and assist those parents who have to take who are on a wait list or are waiting for child care within our facility, so that they don't have to pay for a huge expense when it comes to providing child care for their children. And as far as behavioral health, because of my previous position as the early intervention manager, when I started a little over 10 years ago with our program, we were working with maybe about 4 children under the age of 5 who had family education plans. When I left, there was 21. These are kids that are being born or suffering the consequences of their parents' drug use, from a lot of it that I've seen, where these children are now having to have educational plans before they even hit the age of 2. My grandson is one of these kids. He was born with a deficit of a hearing loss, which I assume, and I contribute, or I can only assume that was probably when his mother was while he was in utero, that his mother, whatever she was doing at that time, caused probably hearing loss for him. Whatever it was she was doing, whatever, maybe she was attending house parties and the music was too loud. I don't know. But, he is currently right now receiving services through our Idaho Infant and Toddler Program. Once he reaches the age of 3, he'll transfer over to the local school district for an IEP. And, we know that he has a disability, and we're working through it. But we need more funding, because our teachers who are in these classrooms with these young children, they are the ones who, they don't get paid a lot of money, but yet they're having to deal with a lot of children with disabilities. And they're not specialists in that area. So we need to apply funding or receive funding to help them get that specialized training for these children who really need it. Thank you.
Hey, we're at the end of our agenda, and I know I wish we had more time with ACF, your awesome program, and we do. Well, I know our tribe will be providing written testimony, so we need to. I want to thank you both for being here. Congratulations again for your appointment.
Thank you so much. I just wanted to offer that my daughters attended early Head Start and Head Start programs, and they made all the difference in the world to them and to me as well. So I'm very pleased to hear your interest and commitment to Head Start as well, and see what we can do. Thank you all.
All right, so we're going to move right into the Indian Health Service, and we have Ben Smith and Julian Curtis. You're on.
Great. Thank you very much, Chair Joseph. And thank you for your leadership in facilitating today's consultation session on these important topics. At the Indian Health Service, we're glad to be here today for the department's 25th annual tribal budget consultation. When you pause and think about that, a quarter century of experience now here at the department in conducting this government-to-government tribal consultation. And for me in particular, sitting right here looking at a quarter of the wall of the past secretaries, starting with former Secretary Shalala, who's smiling at me, who really led the efforts to get the department's first tribal consultation policy in place. I feel that all of them are smiling at me, but also looking at me, holding me accountable for what I'm about to say. So there may be a little bit of intimidation. But with that, the Indian Health Service, we appreciate every opportunity that we have to engage with tribal leaders through this and other forums to discuss priorities for the Indian Health Service budget. And in particular, I really want to thank those tribal leaders who met with the Indian Health Service yesterday during the one-on-one sessions. For the Indian Health Service, tribal delegation meetings are really our most intimate form of tribal consultation. It really provides that opportunity for us to hear firsthand those issues, accomplishments, challenges that you're facing as tribal leaders in your community, and ways that we can work together as governments to find solutions. So for our session today, we have two components. First, we want to provide a brief overview of the fiscal year 2024 President's budget. Then we'll end our session with testimony and questions and answers. We want to reserve as much time as possible. At the Indian Health Service, we are committed to providing quality health care consistent with our statutory authorities and our government-to-government relationship with each Indian tribe. And I want to underscore that, each Indian tribe. Our mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. Tribal consultation plays an important role in our IHS budget process, specifically in meeting the Indian Self-Determination and Education Assistance Act requirement that on an annual basis, the Secretary shall consult with and solicit the participation of Indian tribes and tribal organizations in the development of the budget for the Indian Health Service. Also, we are committed to conferring with urban Indian organizations consistent with the Indian Healthcare Improvement Act. So the budget formulation process always begins with tribal consultation and urban confer through the National Tribal Budget Formulation Work Group, where tribal leaders submit their budget recommendations to the Indian Health Service and the Department of Health and Human Services on an annual basis. In the fiscal year 2024, the work group recommended $51.4 billion in mandatory funding for the Indian Health Service. And our friends and colleagues at the National Indian Health Boards are passing out a book to everybody who's here that really documents and delineates the details of this request. And certainly the top priorities that were identified, primarily increases for hospitals and health clinics, purchase and referred care, the Indian Healthcare Improvement Fund, dental services, and alcohol and substance abuse. The work group recommended the enactment of advanced appropriations if mandatory funding was not enacted. In the President's fiscal year 2024 budget, it is what you see in what's publicly available now is all built on these tribal recommendations. For example, the budget includes significant funding increases beginning in fiscal year 24 to make progress towards the funding levels recommended in the top tribal priorities. The budget also requests mandatory funding starting in fiscal year 2025 for the entire Indian Health Service budget, consistent with tribal recommendations. Over the 10-year window, the President's budget would increase funding for the IHS by $192 billion, or 519% above where we are today. Just think about that. That's significant. This is a historic funding level that's being requested in the fiscal year 2024 budget. And these are necessary to meet our federal responsibilities and significantly expand direct healthcare services, including many of the issues that we heard from you directly or in sessions this morning, primarily around cancer, dementia, dental health, and long-term care. While this mandatory formula addresses many critical health care needs, the Indian Health Service recognizes that we must continue to work in consultation with tribes and confer with urban Indian organizations and work with our partners in Congress to ensure the budget is structured and implemented correctly with the resources identified over the next 9 years. To this end, we at the Indian Health Service will engage in tribal consultation and urban confer to seek your input that is needed to inform and make decisions to further refine the mandatory formula structure prior to the release of the fiscal year 2025 President's budget. So please watch for announcements as those consultation and urban confer engagements move forward. Before I end and turn over to our Chief Financial Officer, almost medical, Jillian Curtis, who's really going to walk us through the details of the President's budget. I want to emphasize that if mandatory appropriations are not enacted for the Indian Health Service in fiscal year 2025, it is absolutely critical that we receive an advanced appropriation to minimize budget uncertainty and to protect health services under government shutdowns. So with that, I'm going to turn to our Chief Financial Officer, Ms. Jillian Curtis.
Thanks very much, Ben, and thank you all so much for the opportunity to meet with you today. Thank you to our colleagues at NIHB for passing out these awesome books. I'm so excited to have one in my hand. Now that we are meeting in person again, I'm going to get back to my habit of carrying this with me everywhere I go, including when we meet with our congressional staff to make sure they know what the tribal recommendations are for 25 and how our future budgets are built off of them. But as Ben noted, I'm going to just provide a brief overview of the FY 2024 President's budget, maybe to help frame our discussion moving forward. But we do want to preserve as much time as possible for testimony and questions. So I'll start by saying that the President's budget builds on the historic $5.1 billion advance appropriation provided in the FY 2023 final appropriation with a two-pronged approach. I know you all know that we got a $5.1 billion advance appropriation, but I just really like saying it out loud. So it's just really exciting. So first, the first prong is in FY 2024, the budget does include $9.7 billion for the IHS, and that's an increase of $2.5 billion, or about 36% above where we are today. So I think that might be the single largest funding increase that has ever been proposed for the IHS. And so this amount includes discretionary funding for our services and facilities activities, building off of that discretionary FY 2024 advance appropriation. And it continues to propose reclassifying contract support costs and Section 105L leases to the mandatory side of the budget. There's also an reauthorization of the Special Diabetes Program for Indians starting in 24 that I'm going to touch on in a little bit. Beginning in 2025, that's when the second prong comes into play, the budget does propose that full mandatory funding for the IHS and exempts the IHS funding from sequestration so that we won't have to relive the horrific impacts of the FY 2013 sequester again. That mandatory formula culminates in a total funding level of about $44 billion in FY 2033. And as Ben noted, that is a 519% increase, or a total of $36.9 billion above the $7.1 billion enacted level that we have today. So major, massive funding increase over that 10-year window. I'm going to talk first about some of the proposed discretionary funding increases in FY 2024, and then I'm going to give an overview of the mandatory funding formula that's proposed in 2025. So let's turn to those discretionary items in 2024. So the services account does include a total of $7 billion in FY 2024. That's a $2.1 billion increase above where we are today. And those dollars really are directed at significant direct health care service expansion. So what we've seen as our budget has continued to grow over the last 10 years is that a lot of our appropriations increases are going to needed contract support costs and Section 105L costs, as well as sort of more targeted funding increases for specific activities like the new Alzheimer's grants that we received 2 years ago or the opioids funding. But we haven't really seen a wholesale significant funding increase kind of across the board in our direct healthcare services lines in quite a while. So the budget proposes an additional $742 million above the FY 2023 enacted level across all of our direct services, direct healthcare services funding lines. So that's over $400 million in additional resources for hospitals and health clinics. It's almost $200 million for purchase referred care. It's an additional $21 million for our urban Indian organizations. So just really trying to significantly expand access to healthcare services. The budget also proposes a significant increase for the electronic health record modernization effort. We are nearing a final award for the system that will replace our PMS. So when we're in the 2025 timeframe, when we're in the 2024 and 2025 timeframe, that's when we're really building that system and looking at our site implementation needs. So that's when the big dollars are really going to need to come into play. There's also some additional increases for operational support in this $2 billion funding boost that the President has proposed to make sure that we are able to provide the best care, really be able to support our core management and inherently federal functions to serve tribes better, and really to make sure that our oversight activities, especially in patient safety and quality of care, are really as ramped up as possible. In the facilities account, the budget includes $1.1 billion, which is an increase of $108 million above where we are today. And those resources are largely targeted towards increasing program support for implementation of Infrastructure Investment and Jobs Act projects, and making sure that there are dollars available for tribes who are implementing those projects directly, as well as some additional resources for maintenance and improvement and equipment. The big dollars in the facility space really come into play in the mandatory proposal. Current services costs like pay costs, inflation, and population growth are fully funded at $346 million, and staffing of new facilities is also fully funded at $82 million. Just beginning in 2025, when the budget would become 100% mandatory under the President's proposal, funding for the agency would automatically grow for all of those costs that we know go up every year. So there are growth for inflationary factors like medical and non-medical inflation, and pay cost growth, staffing for new facilities, funding for newly federally recognized tribes when they are federally recognized, full funding for the health IT modernization effort, and funding increases to address key backlogs like the 2018 level of need funded analysis and the 1993 healthcare facilities construction priority list. But we're not just going to stop there, right? Yes, the budget provides $11.2 billion to fill in that level of need funded analysis that was completed by the Indian Healthcare Improvement Fund work group over the first several years of the budget window, but that analysis is from 2018. So there is continued growth beyond that $11.2 billion into the out years to recognize that there are still costs beyond that analysis. The healthcare facilities construction priority list is from 1993. Happy 30th birthday, healthcare facilities priority construction list. Can't wait to get you out of the way. We fully fund that, and then we also provide significant additional construction funding to start to support facilities that were not captured on that list, and to support some of the new facility types that were included in the Indian Healthcare Improvement Act reauthorization that haven't been funded yet, like dialysis and long-term care centers. There's also some new increases for some new and expanded activities, including $108 million for the President's Cancer Moonshot, in recognition of the fact that both prevalence and mortality of many cancers are significantly higher in American Indian and Alaska Native communities compared to the general population. And there's also increased support for public health capacity building and the treatment of long COVID in recognition of the lessons learned from the pandemic. So the approach of funding all of these things through a formula instead of sort of set funding levels will really ensure that the budget grows appropriately over time, meets those increasing needs, is flexible enough to change depending on what's happening in a given fiscal year, and really also gives us the opportunity to work with tribes, urban Indian organizations, and Congress to refine the formula over time to make sure that these needs are fully addressed. Finally, I'll just end on the reauthorization of the Special Diabetes Program for Indians. The budget proposes a 3-year authorization that is shorter, right, than a permanent reauthorization. However, it does grow the program to $250 million in 2024 and increases that funding by $10 million each year, which is about what medical inflation would be. So we've captured the funding elements of the proposal and recommendation of the National Tribal Budget Formulation Work Group there. So I'm going to go ahead and wrap up my comments now so we can move into our dialogue, and I'll just thank you for your time today and turn it over to you, Chair.
Okay, I get the first part of this, and I just have to say this is being here 20 years ago, and throughout the years, some of the tribal leaders that we've had here. I remember Darrell Redigo stating before he gave his testimony that because he lost his brother, asked for his brother's strength to be able to read out the testimony to help him to get through it, and to me that was very powerful to hear that. Some of our people that have been on the work group aren't here anymore, and this past year we lost a really strong leader from the Arizona area, and out of respect I won't say her name because it's our belief we don't do that until the family has time to mourn, and so, but she was a very powerful leader, and anyway, so I asked for those same kind of strength so I could do this today. Anyway, so Waihaskakwasi Yuhutkani squeezed good after, or Waihaskala, I'm still mourning back home maybe. Good afternoon is what I said. Badger's my name. I'm Councilman Andy Joseph from the Calvo Confederated Tribes. I serve as a co-chair for the IHS Budget Formulation Work Group. I'm joined here today with President Parton from the Wichita Affiliated Tribes of Oklahoma City area representative on the work group, and she'll be helping me present. The IHS Budget Formulation Work Group met on February 14th and 15th to provide input on IHS budgets and policy for the 2025 budget requests to Congress. I'll start with some opening remarks then we'll turn it over to President Parton to provide highlights from our National Tribal Work Group. 2 decades ago, tribes and IHS worked with a team of economical experts to produce the first IHS needs-based budget. Since then, the work group updates its estimate using the most current population and healthcare cost information. The cost to achieve health equity for 574 tribes in 2025 is $53.9 billion. Yeah, $53.9 billion. I think we got to say that almost 3 times. But to me, that's really an important number, and the amount of tribes is very important as well. For comparison, the latest enacted budget for IHS is about $7 billion, or roughly 7 times less than the work group estimate for 2023. Excuse me. One of the first issues that I would like to raise is trying to produce a budget recommendation 2 years out without a president's budget for the upcoming year. When we don't know what the administration is asking for, it is hard to provide collaborative input and advance new policy. Tribes need a timeline that allows us to collaborate and develop meaningful requests that build off both current and future plans of the administration. Good and bad, I understand the budget is embargoed from tribes until it is published. The timeline may work for budget offices that are allowed to review unpublished budgets, but for us, it makes the work less meaningful. Let us work together on a timeline that allows the work group to build on success instead of having to guess the next move. I want to thank the administration for its commitment to continue to work with tribes and Congress to move towards sustainable, mandatory funding for IHS. Full and mandatory funding for IHS remains the #1 request for the work group. One of the work group's concerns is with unfunded provisions in the Indian Healthcare Improvement Act. Full and mandatory funding must include things like services currently authorized but unfunded by Congress, as well as the cost of facility maintenance. As a result of lessons learned from the pandemic, the work group also requests requiring funding and flexibility authority to build tribal public health infrastructure. We are also encouraged that the President's budget calls for advance appropriations until IHS funding is made mandatory. The 2023 advance appropriations enacted for IHS include some accounts and flat-funded accounts it did include. We are happy to see that the President's 2024 budget includes and requests for additional resources over flat funding. And another very important item that rose to #2 in our request is to permanently exempt IHS programs from budget cuts or control measures. Some members of Congress have been proposing fiscal year 2022 enacted amounts for 2024. This is a loss in purchasing power greater than the impacts of sequestration in 2013, which took a devastating $225 million out of the IHS budget. We are only funded at 1/7 the need estimated by the budget formulation work group. Imagine living on only 1 day's worth of groceries per week and then compound that over decades. Cutting the IHS budget will do almost nothing for the federal deficit, but it will destroy our nations. At home, we'll continue throwing dirt on our people, burying them, and that I can't. We have to carry that weight on our shoulders. When we come back here, we want something to happen. Please, an important part of the FY25 formulation is to protect IHS in 2024 and beyond. The work group continues to call for an end to competitive grants which detract from our ability to provide sustainable patient care. Federal treaty and trust obligations must not be provided through competitive grants. Rather, funds should be provided directly in existing tribal funding agreements. Competitive grants create two categories of tribes: those that have the experience and resources to secure competitive awards, and those that do not. This creates further inequity in an already inequitable funding environment. Our tribes unite in our position that honoring tribal sovereignty and self-determination must be upheld regardless of how IHS services are received. Just because a tribe chooses to receive direct services from IHS does not mean it forfeits their self-determination right to direct the best way to use scarce resources for the benefit of their people. The work group requests that IHS be granted greater budget flexibility, especially at the local level or local service unit level, to reprogram or transfer appropriations to meet local health, local priorities as directed by the tribes who receive the services. I've talked about this in some of our work groups. We 12 areas submit what they need, but what's enacted is what we end up with sometimes, and that can cause lives to some of our people. Lastly, I'm compelled to address the rapid growing opioid crisis in Indian country, including the alarming number of overdoses of our citizens from fentanyl and meth use. Tribes are not immune from the behavioral health crisis facing America. Chronic underfunding of behavioral health services include mental health and substance use disorders for American Indians and Alaskan Natives have amplified these issues. We implore the IHS to work with its sister agencies at HHS to develop comprehensive public health, mental health, and substance abuse treatment options that promote tribal self-determination and include these in the budget. I'd like to now turn the floor over to President Parton to discuss some of the program's highlights in the work group's 2025 request. Ms. Parton.
Thank you. Terry Parton, I said, how are you all? My name is Terry Parton. I am Wichita, and I am president for the Wichita and affiliate tribes. I am also the Oklahoma City representative, or one of the Oklahoma City representatives for the budget formulation work group. The IHS National Tribal Budget Formulation Work Group requests funding for each discretionary line item in the IHS budget and for the special diabetes programs for Indians. I will highlight a few key program-specific asks, but I encourage you to read the work group's entire budget request so that you get the full picture of the health needs of Indian country. A lot of effort goes into the IHS National Tribal Budget Formulation request, which includes narratives and hot issues from each of the 12 areas. The work group is committed to supporting a budget policy statement that no IHS program should lose ground from year to year. Our first request provides an adjustment to maintain current services and fulfill any binding obligations such as staffing, packages for new facilities, contract support costs, and 105L leases. This adjustment guarantees at a bare minimum current services and binding obligations are fulfilled before any increase is proposed. Within clinical services, you see some of the largest proposed increases by the work group, such as HNHC and PRC. I will discuss some of the special items that were brought up for these line items during the February work group meeting. Hospitals and health clinics remains a top funding priority. Within that line item, the work group repeats its recommendation to expand the community health aid program nationally, including additional expansion in Alaska. Another priority within the clinical services line is the electronic health records, which includes tribal health IT. The EHR line item currently provides resources for IHS health IT modernization, but it does not include full funding for tribal health IT modernization. The longer we wait, the more expensive it will be, and tribal health care will lag further and further behind the health care that other U.S. citizens receive. We need resources for both IHS and tribes for health IT. We also need a way to reimburse tribes that have invested in IT modernization already. So let's talk about dental services. During the February meeting, I shared a story that explained the unacceptable lack of access to dental services that put a tribal citizen in the emergency room with a life-threatening infection. This situation is not uncommon and results in higher costs, which IHS later had to cover through PRC once his abscess led to him being put in the hospital, put on a ventilator, and almost losing his life due to the lack of proper dental services. We need expanded dental services so that we can address patient health before it becomes life-threatening. When we wait until health is an emergency, it ends up costing IHS more than intervention at an earlier stage. This is not limited only to dental care. We must do a better job at funding preventative care for all areas like cancer. Early intervention not only saves lives, but reduces health costs. The mental health and alcohol and substance abuse lines are also within clinical services. There is so much to be said about the need for additional behavioral health resources. One of our work group discussions emphasized the fentanyl crisis, which, like most health crises, affects Indian country at higher percentages than other U.S. populations. The work group is pressing the administration to fully fund the request to address the opioid and substance use crisis in Indian country. Purchased and referred care continues to be one of the top priorities for the work group due to the chronic underfunding of IHS direct care services, which drives more of our citizens into the PRC process. Further, some areas have little or no IHS facilities, and it makes them uniquely and disproportionately reliant on PRC for care. Within preventative health, the work group continues to emphasize the importance of public health capacity and personnel, including public health nursing, health education, Alaska immunization, and the community health representative programs. Funding for tribes as public health authorities is largely non-existent, but when funded, we see the immediate positive effects of public health efforts and programs such as the Special Diabetes Program for Indians. Cancer is one of the leading causes of death, and creating a cancer prevention program modeled after the Special Diabetes Program for Indians should be a top priority for the Indian Health Services. We ask that IHS support these vital preventative health programs and promote tribal capacity as a public health authority, which will effectively reduce cost on other IHS programs. Within other services at IHS, the work group requested an increase for the Indian Health Professions line. We must address the critical gaps in staffing, recruitment, and retention throughout IHS. One solution that tribes propose is to create a pipeline of an educated workforce that is connected to the community and the people that they serve. With additional resources for the Indian Health Professions line, tribes and IHS can work together to develop and sustain this pipeline of trained healthcare professionals. IHS needs to make sure that students who participate in the IHS scholarship program are able to return to their own communities to fulfill their service requirement. We know that our people dream of returning home to help their people, yet when they enter the IHS scholarship program, they are often sent off to other areas to fulfill their requirements, and then they never have the opportunity to return home to serve their own people. We have to do better to make sure our people are able to work in their own communities. In the IHS facilities line items, there is a lot to be said, but the needs are also clearly evident without words. We need more resources, not just for health clinics and hospitals, but also for staff housing, health-related infrastructure, and to fund innovative ideas proposed by tribes such as the specialty care referral centers. Much discussion during the work group meeting centered on the need to create a new budget line for operations and maintenance funding for sanitation facilities once constructed. O&M for sanitation is currently non-existent. During the meeting, I shared examples where we have the Office of Environmental Health that can build a line to a home, and operations and maintenance, O&M, that can repair a faucet leak in the home, but there is no funding available to fix plumbing issues in between those 2 points. There are high costs associated with the need to demo a portion of a home foundation to access pipes for repair. While those repairs might be a homeowner's responsibility, many times they cannot afford these costs. Not fixing these issues leads to environmental health and safety issues with sanitation and sewer issues. The work group requests that IHS immediately request the authority and funding to address this need and protect the sanitation system investments that are put into those homes. Finally, I want to close today with the Special Diabetes Program for Indians. SDPI is up for reauthorization in 2023, and the program has been in authorization limbo for nearly 2 decades. The program has proven effective at reducing health care costs for the federal government. We know that this consultation is for the 2025 budget, but we encourage the administration's support to reauthorize this program, increase funding, and allow for tribes and tribal organizations to receive these funds through ISDIA contracts or compacts. In conclusion, I would like to again encourage everyone at HHS to take the time to review the written request of the work group and continue to stay engaged with tribal leaders in our historic progress for Indian health. As stated earlier, Congress provides about 7 times less than the estimated need for IHS, an amount that currently excludes authorized but unfunded provisions of the Indian Healthcare Improvement Act. The chronic underfunding has created a healthcare crisis in Indian country. Full and mandatory funding for IHS is necessary to begin to achieve health equity for all American Indians and Alaska Natives. We implore you to make every effort to see that this budget is fully funded for our Indian people. Our 2025 budget request for IHS is paramount to honor trust and treaty obligations and to address the health inequity crisis among American Indians and Alaska Native tribes. Thank you for your time and allowing me to present today on this budget formulation work group. Thank you.
President Parton has to do her presentation for her tribe. She has a flight she needs to get to right away, so she'll go then President or then Chief Bill, then Nate.
Thank you. I came and I was asked to do this also, so I do want to do this for my own people, my Wichita people. My name is Terry Parton. I'm president for the Wichita and affiliated tribes, and I was having a hard time trying to figure out what I was going to say, what stories I would bring up. Do I bring up the dental story about Jared or Gary and his oxygen issue? And I say that because when I come, as you've said before, I think it's Chairman Lewis. When I come here, I'm not coming on vacation. I don't like sitting in hotels all the time, but I bring my people with me. And so I want to tell some stories today about the needs of our people. So I want to talk first about long-term care. When I think about that, I just recently visited some of our tribal elders in the nursing homes, Stuart and Chris and Michael and Gwen, and I want to tell their stories. Long-term care is authorized for IHS through the Indian Healthcare Improvement Act, but unfunded by Congress. More specifically, it authorizes hospice care, assisted living, long-term care, and home and community-based services. Medicaid and Medicare cover some of these expenses, but without funding to establish our own hospice and long-term care services, we are reliant on third-party providers that may not always be culturally competent or provide the level of care we expect for our elders. We need funding for the authorized provisions for elder care in the Indian Healthcare Improvement Act. And I say that because like I said, I just recently visited some of them. Some of them didn't need to be in those centers. They needed more of like an assisted center, but they were in a nursing home. One of my elders, and they, like you said, how to respect the one they call Rochelle, and that's how we say that when somebody's passed. You know, her family, she was at home dying. She got put on hospice. They called hospice, and the lady that answered that weekend asked them why they were calling her, because she was off. They needed to talk to someone else. And so I tell that story because we need our own hospice, somebody that can take care of our people, that knows, you know, how our families are and stuff. And so again, I bring those personal stories with me. Now I'd like to mention a few things on dementia and memory-related diseases. According to your own most recent budget justification, as many as 6 in 10 older American Indian and Alaska Natives with probable dementia remain either undiagnosed or unaware of their diagnosis. As far as a budget consultation with the IHS, this one is complex because we know this administration has taken historic steps to increase funding for the Indian Health Service. Maybe the most important story I can share for our greatest champion in this process is that getting people to see a doctor is hard. Getting them to follow up is even harder. This means those moments of connection with the community, wherever they happen, are critical. It also means that culturally competent care is transformation in the healing process, and we need to make sure that we listen to our people. Sometimes doctors know everything and know how to treat people, but they really need to listen to our people. I've had that same experience at IHS where I knew something was going on and the doctor would not listen to what I was saying. And I explained to him that I know why my people get frustrated and go home, because they're telling you what's going on and you're telling them the medicine. You need to make sure that they listen. I did express about our one of our employees with Beth and her issues with her dad and trying to get him diagnosed with the dementia. That's another case. Listen to what they're saying, and just because you don't see something right then and there doesn't mean there's not. People don't just go to the hospital to go to the emergency room unless there's something really wrong. Our elders are our lifeblood. They keep us connected to our history and traditions. They serve an important role in childcare and education as part of our extended families. And this is a service we can't go without. So when Congress doesn't adequately fund elder care, we do whatever we can to provide for our people. This is just something that we have to do. There's no other way. And then lastly, I just want to talk about an issue affecting our elders, but more and more it is affecting our people no matter the age, and that's cancer. I have a whole list of people here that I know in my tribe that have cancer or have died with cancer or who are currently going through treatments. The President's budget included funding for the administration's Cancer Moonshot Initiative for IHS for the first time in 2024. This program outline is similar to the SDPI program, and the Oklahoma City area for the last several years has put this in as a hot topic to provide a program for cancer similar to the SDPI program. And this combines prevention, treatment, and public education. To that end, we hope the IHS will continue its support for programs that save lives and reduce costs on other federal programs like SDPI has done. One difference from SDPI that we would recommend is to allow funds for the Cancer Initiative to be administered through self-governance funding agreements, and of course make sure that there's consultation before those funds are put out. Empowering tribes works and reducing administrative burden is in the best interest of American taxpayers. Thank you to NIHB, specifically AC, Tyler, Katrin, and Carolyn for their assistance in preparing draft comments for tribal leaders to help us advocate for the health needs of our people. Thank you.
Chief Bill.
Chief Bill, thank you, Andy. For the record, my name is Chief Bill William Smith. I am the chairman and the Alaska Area Representative of the National Health Board. As a Vietnam War veteran and retired Army Sergeant, I am proud to have served my country and to continue in public service by serving tribal nations through the National Health Board. Since 2003, tribal leaders, technical advisors, and other policy advisors have met during the annual tribal budget formulation session to collaboratively develop an estimate for the full IHS funding. The IHS need-based funding aggressive cost estimated for fiscal year 25 is $53.85 million. Or the workshop continues to request the hospitals and health clinics and purchase and referred care Indian Health Service line items received the largest increase. The workshop also continued to request that alcohol and substance abuse, mental health, Indian health care improvement funds, and healthcare facility construction line items receive the next largest increases for Indian Health Service. Indian Health Services spending should be provided through mandatory direct appropriations with adjustments for inflation and population growth, and the allocation mutually agreed to by the tribal governments. And the National Health Board supports tribes in their call for direct appropriations configuration and status. Until the Indian Health Service has provided mandatory direct appropriations, advance appropriations for the Indian Health Service are consistent with the treaty and trust obligations, reaffirming in the Indian Health Care Improvement Act. The advance appropriation enactment in fiscal year 2023 ombudsman excluded certain amounts in the Indian Health Service budgets and flat funded the Indian Health Service account that it did include. A flat rate funding Indian Health Service need 24 adjustment at a minimum for fixed costs and staffing for newly completed facilities, and should also include the amount required by the Indian Health Service budget work group. The Special Diabetes Program has grown and become the nation's most static and effective federal initiative to combat diabetes in Indian country. The Special Diabetes Program has effectively reduced incentive and prevailed the diabetes among American Indians and Alaska Native, and is responsible for a 54% reduction in the rate of the end-stage retinal disease and a 50% reduction in diabetic eye disease among American Indians and Alaska Natives. A 2019 federal report found the Special Diabetes Program is largely responsible for $52 million in savings for Medicare expenditures per year. Still, diabetes and its complications remain the main contributor to the death and disabilities in nearly every tribal community. The National Health Board strongly supports the permanent reauthorization of the Special Diabetes Program at a minimum of $250 million annually and an automatic annual fund increase matching to the rate of medical inflation. The National Health Board also supports amendment to the Special Diabetes Authorization Status, the Public Health Service Act, to permit tribes and tribal organizations to raise special diabetes programs funds through self-determination and self-government contracts and compacts. The Indian Health Service budget remains so small that spending cuts or budget controlled measures would not result in any meaningful savings for the national debt, but it would devastate the tribal nations. And as Congress considers funding reduction in 2024, Indian Health Service must be held harmless. Congress must ensure that any budget cuts, whether automatic or in special, hold Indian Health Service and our people harmless. We cannot balance the budget on the back of the first Americans. And with that being said, I'd like to read into the deal a quote from another elder. We are the people with special rights, guaranteed by our promises and our treaties. We do not beg for these rights, nor do we thank you. We do not thank you because we paid for them. The God help us, we paid, the price was absorbent. We paid for them with our culture, with our dignity, and our self-respect. And we paid and we paid and paid. So That's all I have to say. And like I said, we're here, and it would be beautiful to see it fully funded, mandatory, and special diabetes program, because it also shows, like we've been talking, if you prevent it, it saves money in the long run. So Awa'ata, thank you for letting me speak.
Okay, I have a list, and our time is getting short. We have Nick, Nate, and then Jennifer.
Thank you, Andy. I just have a brief question, I hope. But this work come from our February 14th meeting here in D.C., correct? And so, I was texting my staff when I seen this. We had more than 7 requests. And in this book, only 7 are listed. And that's a concern to me. I see, one that I'm always going to be vocal on is the fentanyl issue. That was listed as a priority. And I do see in here that there's a page on the fentanyl issue. But I get concerned when we lump things in. When we did that 12, 14 item list, we didn't put things into priority 1, A, B, and C. They were all standalone items. And so I would bring that up. And Andy, I know you're a co-chair, but to our federal partners, when we have printed documents like that and we merge things in like that instead of leaving them standalone, that really can diminish how it looks as a priority. At least that's how I feel as a tribal leader. I don't like seeing things get lumped in. And the only reason I notice that is just because, as I mentioned, I'm going to be a voice always on the impacts of fentanyl, because I'm tired of us burying children, burying our loved ones every week to that issue. And when we made that recommendation, it was a standalone one. And I know, Tyler, you might have a comment too, but I have a lot of concerns when we do that overall. It's frustrating. And maybe I'm looking at it wrong, but I remember on that list we had a lot of different priorities, and that took us a long time to agree. And I can acknowledge as well that things can change when staff works on things, and we have to do things for a certain reason. But if tribal leaders from across the country travel to D.C. on Valentine's Day, and I'm sure some of them became single if they couldn't bring their partner, but we can't change things when those tribal leaders come in, and we did that in an official meeting. That's just my concern, and I want to highlight that, just because that shouldn't be. We had more than 7 recommendations, and I don't see 7. I just see 7 in here. Oh, thank you.
Okay, Nate.
Appreciate that. Nate Tyler, McCaw Tribe, Washington State. I guess I want to bring up a couple issues. One is I think she mentioned the chat program and referred to it as expanding in Alaska, and it's actually expanding in the lower 48. So it's something that the Portland area has been pushing for quite a few years. We've requested extra funding. We got the extra funding, but that funding never trickled down to the Portland area. Alaska was able to keep that funding. That was above and beyond previous funding. So the request is, let me see real quick, $60 million for the national CHAP implementation, $6 million going to the Portland area. $5 million is going to support community health aid, behavioral health aid, dental health aid therapist education program, which just opened up in the Skagit Valley College. So I think that's important to note. We've been asking that for quite some time now. I missed last week's consultation, so I want to address the sanitation deficiency, especially for McCaw. My first term on the Tribal Council was in 2000. One of my first trips here was on our water issue. We're in 2023 still dealing with our water issue. We do appreciate everything the IHS has done to date, and especially this last year, the money that they put towards the sanitation efficiency report, tier 1, 2, and 3 projects. We don't want to miss out on that next round of funding that's going to actually deal with tier 2. The money's going to be there, and we definitely need to deal with tier 2, and hopefully tier 3 can get moved down to tier 2 or 1 also. I think that's really important, and I say that because myself, Andy, and Nick were in here on the Hill a couple months ago, and we were kind of surprised being told from some congressional folks that you know, they had asked IHS for to provide some information, and they weren't getting it, and it's been a couple years, is what we were told. And we don't want to be in a position, we've gotten this far today, to be in a position where they're going to take money back from us. We don't want to be in that position. We want to work together, definitely work together, and you know, zero out this funding that we're getting. I mean, we're lobbying for this money. It's serving needs, and we don't want to be in a position to where they're going to take it. I think that's really important. So the SAP program, small ambulatory program, is another thing I want to talk about. The Makah tribe, we appreciate it. We have been awarded the SAP, but even though we were awarded, we're looking at building probably a $24 million health clinic. So we're getting whatever it is, $2.5 million. We have to constantly come up with our own funding. We don't all have grant writers. So what we end up doing at Makah is we do get money from the government. We do go after some other sources of funding, but we end up having to pay a huge percentage of the overall cost with our hard dollars. So we're tying up resources, collateral, land. Our land, we're giving up land. We're a natural resources tribe. We log. So we're giving up that logging area for facilities. So we don't want to make any major changes to the SAP program. We were on that call recently. But we want to see that raised to 3.5 million or whatever it's going to be. The Portland, everybody knows the Portland area doesn't have hospitals, so we do rely on grants like that to build facilities. So we don't want to rush anything. We definitely don't want to give congressional folks any reason to take any money back. So I think that's really important, but just to work together and move forward in the next year or two. So that's all I got, Chairman. Appreciate it.
Thank you. Jennifer Webster Niyungets. Good afternoon. Jennifer Webster from Oneida Nation, council member and representative for the Bemidji area. Just a few things quickly because I know we're short on time. I wanted to mention the limitations on IHS PRC services for behavioral health, and several others have talked about that. So I just wanted to reiterate our request. How can we work with IHS to update the PRC guidelines or exercise greater authority to make exceptions to those limits? And also wanted to mention the permanent reauthorization of STPI. A lot of us have talked about that as well. So I just want to reiterate the request there. We ask IHS to provide technical support to Congress to support modernization of STPI, including permanently reauthorizing STPI with automatic annual funding increases tied to the rate of medical inflation, increase the baseline funding to address stagnant funding and expand reach of the program, support tribal priorities, which include amending STPI's authorization statute, the Public Health Service Act, to permit tribes and tribal organizations to receive STPI funds through self-determination and self-governance contracts and compacts. And then also wanted to speak about the RPMS health IT modernization, and I think we've all kind of touched on that. So I just wanted to reaffirm my request. A portion of the funds allocated for RPMS replacement and health IT modernization should be made available to tribes for reimbursement and ongoing support for their commercial off-the-shelf EHR systems. And we also all spoke about the funding and resources for long-term care. So our request is the federal government cannot fulfill its trust responsibilities to our people without funding long-term care. We ask IHS to work with the HHS agencies, Congress, and tribes to secure additional funding for these vital programs. And then mandatory funding for IHS. Oneida Nation supports full and mandatory funding for IHS and asks IHS to continue to work with administration and Congress to achieve these long-term goals. And then also wanted to mention the IHS Bemidji area funding levels. In 2017, Bemidji's area's level of need funded, the LNF, was 40.5%, which was the lowest of all IHS areas. At that time, IHS-wide average level of need funded rate was 46.6%. An ASPE report from July 2022 reported the overall IHS-wide level need funded grew to only 48.6%. Several tribal leaders in the Bemidji area have expressed their concern that the Bemidji area continues to be underfunded by IHS. So our request, IHS should update the level of need funded, the LNF tables detailed by IHS area, and share this information with tribes. This will allow tribal leaders to determine if the work of the Indian Healthcare Improvement Fund work group has made the impact that it intended. And then our request, tribal nations rely on data to advocate for funding. Providing regular updates to LNF tables will show the true need of IHS and the shortfall that the budget needs to overcome to truly meet the needs of tribal communities. We encourage IHS to share regional funding data with tribes and regional health boards. And with that said, I want to reiterate what Mr. Lewis said yesterday in regards we don't want to pit tribes or regions against each other, and we don't want to harm another tribe asking for that increase for Bemidji area. With that, thank you so much.
Okay, it's actually, we're actually kind of running over, and I don't know if we're flexible or not. I know I got one more hand up, if it's okay. Go ahead.
Cool. I just have two things really quickly here. So as my colleague, Councilman Tyler, mentioned, we're in the process of moving our clinic, and that's a constant battle in terms of funding. So one of the asks that we have is permanent funding of the 105L leasing program would really go a long way to helping us out with that and some of our budget shortfalls and things. The second thing I have is I also want to thank Oneida for bringing up the EHR issue. We deal with RPMS in Nia Bay at the Sophie Tredovic Indian Health Center as well. And I ran as an EMT firefighter for 5 years, and I can think of many examples in which RPMS is, high technology from the 80s. So it's so there are a lot of examples that we've had where we have providers who are referred out by IHS people. So they go to Port Angeles, a specialty clinic in Seattle, Port Angeles, Silverdale, they're all a couple 100 miles away from where we live. So out there, they're all on Epic, which is a modern EHR, and Epic talks to other EHRs. And so when a physician updates someone's medications, they put the order in, and that's charted in Epic. People who are on Epic, which is almost everywhere else in the state, can see that order. So what happens with RPMS is people can't see that right away, so they need to fax the order to our clinic. So we have, and the only way that gets into the chart in RPMS is if somebody scans it and uploads it into the chart. So we have staff that spend 15 hours a week scanning orders from external providers into our charts in RPMS. And there have been a few times where because these orders are not automatically updated in someone's chart. Say someone goes in for a specialty appointment on a Friday or a Thursday, and the provider changes a med. You know, if these people are on multiple meds and they have multiple issues, sometimes the medications that get prescribed don't really jive with one another. So when one med gets changed and that's not updated right away because it goes into the scan pile and it has to get scanned in by somebody who's already busy doing other things as well, that creates a medical emergency over the weekend because there's not an updated note, or the provider, you know, couldn't see what medications have been changed. So it's a big issue for us, and I just hope you take that into consideration. Thank you.
Well, I want to thank you both, and I know IHS is funded at the level that it is, and you know, it's really hard. We got our work cut out for us to lobby as much as we can to help educate Congress. Anyway, I want to thank you both. Go ahead, Ben.
Thank you again, Ben Smith, Deputy Director, IHS. I just want to thank all the tribal leadership here for the comments, questions, recommendations that you shared. We know the comment period is still open for 30 days, so we look forward to that. On behalf of the Indian Health Service, in the room you do see a number of key leaders: our new Deputy Director for Intergovernmental Affairs, Stacey Eckerfee, our new Special Advisor to the Director, Joshua Marshall, and our new Chief of Staff, Captain Cleland, in the room, as well as we understand that there are many viewing this session today. So we encourage everybody to bring the comments. If they're not, of course, records help, but if it's not properly reflected in there for your individual tribe, we want to know that. So I've had the benefit to be here this morning and yesterday, but you know, starting with the Secretary's remarks and his encouragement to really coordinate among agencies. I think through each of the operating divisions that reported today, Indian Health Service came up. We are inextricably linked to the health and human service factors of providing comprehensive healthcare wellness services. So we want to reiterate our commitment to working with each of you as tribal governments. It is so important, and we will certainly work with our federal colleagues to bring the needed resources to the extent we can to get us across the finish line or even enter into new territory of some of these areas that we're hearing today. It's quite extensive, but we really take it to heart, and we have taken a lot of notes today, and certainly look forward to working with you moving forward. So on behalf of Ms. So, I'd be remiss if I don't underscore our commitment to accountability. A lot of the items that you did identify, that were identified today, are laid out in our action plan, which was published in January. We want that to be a living document, whether it's talking about our improvements to purchase referred care, exploring new funding, and if you're not seeing the results, we need to hear them. That's the only way it's going to help us collectively change and progress. So with that, again, thank you so much. From the bottom of my heart, there's a face, there's a patient behind each word we're sharing today. Whether it's a policy, budget decision, you name it, these are our family. We need to take this seriously, and we certainly do. I can express that and tell you firsthand on behalf of every IHS employee, we are dedicated to this mission and working with you in a government-to-government manner.
I want to thank NHB for the staff that they helped put together this. It's a lot of work. And every area has their technical reps that attend there. Also, because it's like 20 years ago, and the first time I ever met Stacey Eckerfee, I'm really glad that IHS actually has her to help her people, probably from her area, where she can really help them, a lot more with her ability. Anyway, I just wanted to acknowledge you. You've helped save the lives of a lot of our people, and that means a lot to me. From the work that you did in this building, and so I want to acknowledge you for that. Anyway, I believe that we open with the prayer. I always believe in balance, and in balance, I kind of would like a lady to give the closing prayer, but.
Mr. Chairman, if I may, just a couple of closing remarks.
Yes, go ahead.
I just wanted to say on behalf of Director Marvin Figueroa of the Office of Intergovernmental Affairs, really want to thank the tribal leaders for being here today. Really recognize that you all traveled really long distances. The stories and the recommendations that you all have shared have been impactful. I was actually talking to some of the HHS staff who have been in and out of the consultation, and some of the follow-up that their principals and their bosses are already making sure that they hear what the recommendations that you all shared are, and thinking about ways we can incorporate them and follow up on them. So you have definitely been heard, and I just wanted to make sure that you heard that. And I also wanted to just reiterate what the Secretary said about more concrete follow-up. We will be sharing a consultation summary report of this budget consultation, and we will be making sure that we are working with our HHS agencies to follow up on the recommendations that were shared. And then I also just wanted to mention, thank you all for being here today, but also just recognizing the tribal leaders and representatives who have watched online. We got some early analytics from yesterday's meeting. We had over 400 people. So who knows how many people watched online today. So we'll be looking forward to getting those. And then I also just want to do a final reminder. It's been mentioned before that the written comment deadline is still open. That deadline is May 19th. So if you have not already done so, please do send us your written comments by May 19th. And you can send us those comments to consultation@HHS.gov. But the sooner you send them to us is always the better. And lastly, I just wanted to thank you, Councilman Joseph, for moderating and facilitating this our consultation today and yesterday. Really, really grateful for all that you do and all that you continue to do. Thank you.
I forgot to turn off my mic. Well, thank you all, and like I said, would you be able to give a closing prayer, Jennifer?
We can stand. Creator, thank you for these last 2 days. Thank you to the tribal leaders that are here and all of our partners that gave their time as well. We pray for our families back at home, our elders and our loved ones, and we pray for safe travels, for everybody heading home back to their communities with a good mind, a good heart, and a good spirit. Amen.
Produced by the U.S. Department of Health and Human Services.